Okay.
Yes, sir. Maybe a little louder.
I'll just get closer.
Okay.
All right. So my case is a 42-year-old female firefighter who came in for low back pain. She had a previous disc herniation in 2015 and is still having residual symptoms from that. She was originally injured doing a bending and twisting motion, like a chainsaw drill, like a training drill. But still is getting low back pain, no radicular symptoms, no loss of sensation or anything. Just low back pain with some pain referring into the glutes. Aggravating factors for her: squatting, lifting, twisting, and then easing factors: rest, heat. Red flags, nothing. Nothing came up there. So as far as my hypothesis, I thought this is probably a chronic low back pain case, just because of the chronicity of the issue, and then kind of how non-specific her pain was on her pain diagram. So she kind of just circled like the entire low back and hips. As far as my exam went.
Anything, can I pause you for a second?
Yeah.
Anything from your chart review or your subjective with her that would put up some yellow flags maybe about central sensitization, psychosocial components, things like that?
Yeah, so that's kind of what I was getting at with the, like, she kind of just circled her whole back and her glutes versus just like a localized spot. So that's what kind of made me, that's what kind of led me to the idea that it might be kind of a central sensitization issue, along with it's been 2 years since her injury. So slump was negative, SLR negative. And then, so the interesting thing is looking at her range of motion, with flexion and extension, she really did not move at all from her lumbar spine. Like, she just used her hips. And she wouldn't even really go into extension just because it made her very apprehensive to do that motion. And like, we couldn't even, like, I wanted to try like a prone press up, or at least like prone on elbows or something. And she wouldn't even go for that. So, and then palpation, unsurprisingly, her lumbar spine is pretty hypomobile all around, just because I think she just tries not to use it, or tries not to move from there at all. And then glutes are pretty weak. So my final diagnosis is, chronic pain with some mobility deficits in that lumbar spine.
How would you describe her standing and or sitting posture?
It's actually it's not too bad. She actually has pretty good posture. And the interesting thing is she is pretty active. I mean, she's a full-time firefighter, but she also does like yoga class twice a week. She does like a spin class twice a week. So she's pretty active, which makes this like kind of an interesting case for me, because you would think, someone that has, this issue and is so afraid of moving from her lumbar spine, you would think would be less active than she is, but she's actually pretty active.
Sure. Did you assess any of that stuff in your initial evaluation, kind of like her squatting, lifting, twisting, she said were aggravating factors? Did you have a chance to look at those?
Not on eval. We started incorporating that in treatment. So towards the end of the like the latter half of our treatment, I started incorporating more functional movement. So we started doing some deadlifts and some squats and like D2, D1 chops with bands and stuff like that. And it didn't look all that bad, really, when we started doing that. Like we would do farmers walks and stuff, unilateral, and all that. You know, she didn't look too bad.
I have one more question for you, and then I'll let someone else ask. You MMT'd her glutes. Did you assess strength of anything else like core musculature?
No, I should have done that. Looking back, I would have looked at her plank, side plank. I would have done like the Bearing Sorensen test. And then I should have looked at some motor control stuff too, but.
And then any sort of, I lied. I told you that was my last question. It wasn't. Any sort of muscle length issues, maybe, I mean, without a great description of her posture, anything like maybe a modified Thomas?
No, I didn't look at that. I just looked at, like, I guess straight leg raise would be the only kind of muscle length issue.
And I asked a bunch of maybe biopsychos or physiologic type questions, biomechanical type questions, and she has had pain for a long time. So it'll be interesting to see in a minute when you present the second half of your case how that kind of plays into it. Anyone else?
Did you address her SI joint, or did she complain of any SI joint pain at all?
No, her pain was mostly localized in her low back. I did do like a PA assessment of her SI, but that didn't really recreate anything. PA assessment of the lumbar spine recreated some pain. So I didn't really focus on SI too much.
And did you do any stability testing with her, lumbar spine with her?
No, I should have, but I didn't. Any other questions? All right, so for my asterisk sign, I used a multi-segmental extension. And then her ODI at initial eval was 24%. Pain was at 4 out of 10. And then her FABQ, her work score was 24, her activity score was 12. I did her first reval after 6 visits. Pain kind of remained unchanged. Her ODI actually went down quite a bit. I don't think it reached the MDIC, but it did go down 10%. And then I neglected to get an FABQ from her on that day. So I'll do that for the next visit. But mostly my treatments have focused on pain science education, number 1. And then I wanted to start out with some mobility exercise and just kind of really get her to try to kind of explore that range of motion in kind of a non-threatening way. So we would do like we started out doing pretty basic mobility exercises, incorporating some like deep breathing techniques, and just to try to get her to really kind of relax and feel, I guess, that she was in control of the movement, and really kind of let her explore that segmental mobility. So I started out with like, lower trunk rotations, open books, cat camel, things like that. Again, incorporating some deep breathing. I would start out her appointments, I'll start out on the bike just to get some aerobic stuff going, but I would have her read the Adrian Lowe book while she was on the bike. and then we would talk about it while she was doing some of that mobility stuff. We did that for a few visits. I wasn't really seeing much improvement, so then that's when I switched gears and kind of started incorporating more of like the circuit training type thing with functional movements, and then some mobility stuff mixed in. And so I eventually got her to do like some mini prone press ups. But I still feel that there was a little bit of a disconnect there. So yeah, I chose to present this case just to see what you guys would suggest doing, kind of reintroducing that lumbar movement for someone who obviously has she has that chronic pain, kind of like what am I trying to say? Like she's a very active person and her job is very physically active, but she still has this relationship with her back that's kind of maladaptive. So it's kind of like this contradiction. Like she's very active, but at the same time, like she compensates for everything. So that's kind of what I want some feedback on.
Did you break down the pain science education like in a separate session, or did you just do it like you said, like when she was doing activity or on the bike?
Yeah, unfortunately, I didn't really get an opportunity to kind of sit down and really focus on that. I wish I did, but I usually have one or two other patients in at the same time. So I tried to incorporate it as much while we were doing other stuff, either when I was doing manual on her or, like I said, when she was doing like mobility. But we would always start out on the bike and have her read the Adrian Lowe book.
I really like that Adrian Lowe book that you're using. Whenever you're talking to her, do you ever relate it back to kind of what she does on a day-to-day basis? Like, big bad firefighter, like how does this relate to her and her problem and why she feels pain with certain movements but maybe not with others? Do you ever talk about that kind of stuff with her?
A little bit. So, one thing she voiced was she voiced concern about being able to perform her job.
That's huge.
Yeah, being in a moment where she has to, either save someone else's life or, save her own life, and not being able to perform in that moment because of her back. That's a very big concern for her, and something that we touched on when we talked about pain science stuff.
Does she get pain? So, like, talking about her, did you talk to her about her job and when she gets pain while she's doing job activities or training activities or anything like that?
Yeah, she said she pretty much has to like modify everything she does and really think about what she's doing as she's doing it, or else she'll be sore for like days after.
Okay. So she's sore for days after, but is she like painful while she's doing it? Or does she just like push through it and says forget it?
Yeah, I think she more pushes through it.
Okay.
But yeah, like I said, like she's a really active person.
Yeah.
And pretty much anything I put her through in the clinic, she was able to do. She would just complain of pain after.
Yeah. Yeah, that's interesting. This is a really good case and does she work for a big city, or does she work for small?
I guess fairly large. We're in Vegas.
Oh, okay. Okay, yeah, that's a big one. And so is she currently working right now?
Yeah, she's full time.
Full time. Do you know her schedule Or have you got an idea of like what hours she works?
Yeah, she's on 24 hours and then off 24 hours.
Right. So how is she sleeping?
That's a good question. Yeah, I don't think I addressed like sleep or sleep hygiene with her.
And how does that affect the way she performs and the way she feels, do you think?
Yeah, I mean, I assume if her sleep isn't the way it should be, that's definitely adding some stress to everything else she's got going on.
Right. So that changes hormone levels. That changes everything. And uh, as someone who has quite a bit of friends in this field, and I did a volunteer position for about half a year doing this, and I had the opportunity to do a couple overnight shifts. It completely throws you off, and I couldn't imagine living the life. Only got to do it for a couple months, but I would say to dive into that a little bit, and that may give you some ground to stand on whenever you're talking to her about this pain science stuff, and really getting her to understand the physiologic component behind the different hormones and how they affect her pain experience.
Yeah, that's a great point.
Especially if she has any external stressors like kids or family life that's adding to that dynamic.
Yep, she's got 4 kids too, so
okay.
Pretty busy woman.
Javier, what kind of manual work did you do on her?
It's mostly central and unilateral PAs. She expressed some anxiety about manipulation, so I just chose to defer that to some future visit once we've calmed everything down, if at all. But yeah, mostly lumbar, PA, UA, some thoracic stuff too.
Did you see any changes in her apprehension with motion, like directly after you did that work?
A little bit.
Mm-hmm.
Yeah, her extension got a little bit better, but not as much as I would have liked.
Mm-hmm. Yeah, the manual component for a chronic case like this isn't as helpful as we'd like, unfortunately. You were talking about her difficulty with the press ups. Did you try some other exercises getting her to explore that motion better?
Yeah, so we tried like standing extension. That didn't work out too well either. We tried like a reverse hyper, like off the end of the table. That went a little bit better, but still, she was still pretty apprehensive about doing that.
Does anyone have any other ideas for trying to get motion?
And I even tried like the Jefferson curl to explore her flexion, but it would go like cervical, thoracic, and then.
It might be worth trying some like unilateral stuff with her. Like I'd try like sideline thoracic rotation or lumbar rotation, like in or lower trunk rotation in supine, just to try and introduce that.
Yeah, that's what I did the first like 2 or 3 visits.
Okay, good.
Yeah,
and definitely still working on the thoracic is good. Now, when you were doing the circuit training, was she sweating, like getting her heart rate up there?
Yeah.
Good.
I had her moving pretty good. Excellent.
And you clearly had her. You were loading her right with the types of exercise too, like deadlifts, squats. So I think you're doing an awesome job with trying to hit it from the exercise component and getting the cardiovascular system. I'd say if you end up having more time, maybe focusing a little bit more on the pain science aspect, like Chris was saying, and educating her about how all these different factors play a role, especially with the concerns about being able to perform her job fully without any restrictions.
Yeah.
Just a question. Is this a workers' comp case at all?
It is, yeah.
Yeah. Firefighter. That's tough, man. That's tough.
Yeah. Yeah, and she was actually talking to me about like maybe like taking some time off work and all this stuff. And so I'm trying to get her, you know, better, quicker, so that, you know, we don't end up kind of on that disability like slippery slope.
Talk her off that ledge quickly.
Yep.
Do you know how long she was off work when the initial injury occurred?
I do know, but I can't remember off the top of my head. I want to say it was maybe like a month or something like that.
It certainly sounds like you're on the right track with some things, and then maybe there's a few other things to add in, a little more thoracic work, trying some other ways to kind of get some lumbar motion, even something like quadruped, like a cat camel moving into extension, or thoracic rotations in quadruped. And I think keeping her sweating and kind of showing her like, look, you can do some hard, heavy work stuff, and you might be sore, but you're going to be okay. And then I think it sounds like the biggest thing is going to be addressing fear avoidance and stress and 4 kids and not being able to do her duties. And that's not like a I can't sit at my desk and teach all day. That's like a life or death type of I can't do my work. So that's a little more stress than we take to work with us each day, I would think.
Yeah, for sure. And I have at least 6 more visits with her, so I'm gonna try my best.
Absolutely. Anybody else have any other questions or comments?
Javier, I just want to comment
I
again
would say,
with incorporating a lot of the pain science stuff that we've been presenting. You're definitely like trying to hit it from every angle with it. So keep up the good work.
Absolutely.
Thanks, man.
Go ahead, James.
I was just gonna say, if you get a chance to maybe taking a second look more into her posture and seeing kind of if there's any type of movement impairments that you can pull out, and maybe address that as well.
Okay.
But good job on the pain science education. Do you think that that's had the most impact on your treatment with her?
I think so. I think we've had a couple like light bulbs go on so far. So I hope we can keep improving on that.
Yeah, for sure. All right. Well, good job, guys.